Start now, ma'am.
Yeah, you can start sharing.
Okay. So till now, what are the steps that we have already covered under conducting a systematic review? Can anybody just tell me the steps that we have already covered? So first of all, we have gone through the topic selection. After that, we have decided on the PICOTS criteria. We have formulated the search strategy. We have searched the databases. Then we have done the screening of the articles, isn't it? After the screening, we have gotten a number of articles. Now there are two steps essentially here. First will be data extraction and meta-analysis, which Madam had already covered. And another step is the risk of bias assessment. I'll just be sharing my screen now. Okay. Is this visible?
Yes.
Okay. So the next step in our conducting our systematic review and meta-analysis is essentially the risk of bias assessment. Two parts we just talked about after screening of the articles. One will be data extraction and meta-analysis, and one is the risk of bias assessment. So why do we need to do risk of bias assessment? So remember that whenever we are searching for the articles and even after screening the articles, whatever articles we are getting may not always all be of the highest quality, isn't it? So we do need to see, assess all of those articles to see what is the risk of bias in it. So just to revise, what is bias? We all know that bias is any systematic error in the design, conduct, or analysis of a study that can result in a mistaken estimate of the effect being measured, isn't it? As we just discussed, all the studies that we will get after screening will not be of high quality. In fact, there is evidence, as the Cochrane website does say, that there is evidence that there are certain features of design, conduct, and analysis of studies. Okay, all studies, even including the RCTs, which lead to bias. And also, there is some evidence that uh, authors do suppress the dissemination of results because of the nature. So what is this? So sometimes it may be that results that are more significant are published faster, or they may be reported more in articles. Okay. So as a person who is evaluating or who is actually going through all of these studies for our systematic review, it is frequently very difficult to know that to what extent the biases have really affected the results or the analysis of a particular study. Okay, so we know that there is a risk of bias, but we can't tell for sure that uh, always that how much bias is there in the study. So now there are certain standardized methods that are there for us to find the risk of bias. Okay, to clarify the concept of risk of bias, risk of bias is an assessment that is done for individual studies included in our review. Okay. So if there are 3 studies that have been included in my review, I will do risk of bias assessment at least thrice in my systematic review. But in fact, if each study is measuring maybe 2 main outcomes that we are evaluating in our systematic review, then for each we will do risk of bias assessment twice. Okay, so for each outcome that has been evaluated, we will do risk of bias assessment. Is that clear? we are doing risk of bias assessment for each study that we will see in our systematic review. Okay. So now this risk of bias assessment is different from another concept, which sometimes beginners do confuse with. So this is different from what is called the certainty of evidence or the quality of evidence. So the certainty of evidence or the quality of evidence is something that is done for each outcome at the end of the review. Okay. So let me give an example. So for instance, in our systematic review, where we had evaluated the effect of corticosteroids on the treatment outcomes in lymph node tuberculosis, we had included 3 studies in our systematic review. Uh, the We had taken, say, 2 outcomes. We had taken 2 outcomes in our systematic review. The first was complete resolution at 6 months, and the second was symptomatic relief at 2 months. So, risk of bias assessment was done once for the complete resolution at 6 months for all 3 studies, and once for the symptomatic relief at 2 months for all 3 studies, while the certainty of evidence was done all at once for the 3 studies together at the end of the review for each of the outcomes being evaluated. Okay. And there is another concept which is also different, which is the quality assessment. So Dr. Aditi will talk more about it in her presentation. Risk of bias assessment is also a type of quality assessment. Okay. So now there are different tools that are available for the risk of bias assessment. So in this presentation, first we will go through the tool for risk of bias assessment in the randomized trials. Okay. So the risk of bias assessment tool for the randomized trials is the Cochrane's risk of bias tool, which is the RoB2 tool. This is the most commonly used tool for randomized trial, and it is a standardized tool with standardized set of questions. Okay. Is it clear till now, the concept of risk of bias assessment? Is it clear till now?
Yes, it's clear.
Okay, okay. I will resume. So now we will talk a little more about specifically the RoB2 tool. Okay. So when randomized trials are being considered, then the recommended tool is the RoB2 tool by Cochrane. So the RoB2 tool, as I had just mentioned, RoB2 tool is used for the risk of bias assessment for each outcome of interest. Okay. Uh, at the beginning of the SRMA, we have specified what are the outcomes we will measure. We will use the RoB2 tool for each outcome in each study. So this is a standardized tool which has 5 domains. Okay. And each domain that has been listed in the RoB2 tool is compulsory that we need to assess it, and no additional domains are required. Okay. Now we will go in more detail, but in each domain there is a number of questions, and you are supposed to answer those questions in a yes or no fashion, and you are supposed to move algorithmically, and ultimately you will get the risk of bias assessment in that particular domain. Okay. I'll just show you. It's something like this. Okay. We'll go through in more detail. So what are the 5 domains in RoB2 tool? The 5 domains are: first, bias arising from the randomization process. We'll go through each in more detail. Then we have bias due to deviations from intended interventions. We have bias due to missing outcome data. We have bias in measurement of the outcome. And we have bias in selection of the reported result. Okay. Now, how is the risk of bias assessment classified? In each domain, at the end of the algorithm, we will get answers like what is the risk of bias assessment. So the three types of ways in which the risk of bias assessment can be classified in each domain would be low risk of bias, some concerns, and high risk of bias. Then after this, once we have the risk of bias assessment for each of these 5 domains, we will tell the overall risk of bias. And the overall risk of bias will be the least favorable assessment across the domains of the risk of bias. Okay. So for instance, if the risk of bias assessment in each domain will be in randomization process, we have low. In deviations from intended interventions, we have some concerns. Missing outcome data, we have low. Measurement of the outcome, we have low risk. And selection of the reported result also, we have low risk. Then what do you think will be the overall risk of bias? Can somebody please tell what will be the overall risk of bias if the risk of bias assessment is low, some concerns, low, low, low in the 5 domains respectively?
Oh, ma'am.
Since it is some concerns in the second domain, so it should be some concerns. Is that clear? The least favorable
Yes, yes.
option here will be some concerns, isn't it? So that is why some concerns will be the answer here. On the other hand, if the domains were like low, some concerns, high risk, low, some concerns, then what would be the overall risk of bias?
High risk.
High risk, exactly.
Oh.
So it will be high risk of bias. Okay, so the least favorable is high risk, followed by some concerns, followed by low risk of bias, as expected, isn't it? And if any of these are high risk, then the overall risk of bias becomes high risk. Okay, if any of these is some concerns, then the overall risk of bias becomes some concern. If multiple of these are some concerns, the overall risk of bias may become high risk. Okay, and only if all of these are low risk, only then the overall risk of bias will be low risk. Okay, so now we will move on. So now the questions that we are asking when we are assessing the risk of bias are called the signaling questions. Okay, so these signaling questions have answers such as yes, no, probably yes, probably no, and no information. Okay, so these are the options that we can select for the answers to each of these questions. Now we will answer yes or no when we know the answer for sure. We have some evidence, like we have good evidence. We will answer probably yes when we don't know the answer for sure, but there is some evidence suggesting that the answer to the question is probably yes. Similarly, for probably no. No information option is selected when we have insufficient information available in the report and it is not appropriate to give any of the above 4 options as the answer without the availability of that information. Okay. So first of all, the RoB2 checklist starts like this with the preliminary considerations. Well, first of all, we have to write the study design. Okay, we have to be very clear about what the interventions being compared are. Okay, which outcome exactly we are assessing for the risk of bias assessment. Okay, as we know, there may be multiple outcomes that have been reported in the studies, but we will assess this as to our outcome of interest in as our systematic review demands. Okay, and we also need to decide that as the review team, whether our aim for the result is to assess the effect of assignment to intervention or to assess the effect of adhering to intervention. Okay, so this we will discuss in more detail when we come to domain 2. Okay, we also need to detail that which of the following sources were accessed to help inform the risk of bias assessment. So definitely the minimum source that we do need to access is the published journal article, isn't it? If it is a published article. Okay, but what we also do need to know is that we should try to access as many related documents as possible. Often, in the case of clinical trials, the trial protocol may be available uh, online. Okay, so then we need to obtain the trial protocol as well. Okay, sometimes it may be a gray literature also. Okay, so whatever it is, we need to take as many as applicable and we need to use them all to do our risk of bias assessment. Okay, so now we will move on to the actual risk of bias assessment algorithms. Okay. So first of all, we come to our domain one. Okay. Bias arising from the randomization process. Before we start, I just want to be clear that the RoB2 tool must be used only in the case of randomized trials. Okay. If the trial has not been randomized, then we need to use other tools. Okay. So now that we have decided to use the RoB2 tool, we first need to assess the domain one, which is the bias arising from the randomization process. Okay, so this is the algorithm where we have the bias arising due to the randomization process. Okay, I also want to mention that where will you get this document where you will assess this risk of bias assessment? So when you're doing clinical trials, the RoB2 crib sheet is freely available online. You can go through it as well as the guidance document where these algorithms are available and also some guidance is available. Okay. So all the things that I'm going to tell you now, like later if you are forgetting, if you need to go through, like you can just go through those guidance documents and you can try to get the guidance whenever you have doubt regarding the meaning of any question. Okay. So in domain 1, the question 1.1, signaling question 1.1 is the allocation sequence random? Okay. So what does this mean? By this means has it been mentioned that what process has been used for randomization? Okay. In this case, the answer will be yes if the randomization process has been exactly mentioned. Okay. And it is an acceptable method of randomization. So what are some acceptable methods of randomization? We know that some commonly accepted methods of randomization could be random numbers generated from a computer, a random sequence generated from a computer, or use of random number tables. Okay. So if any of these has been mentioned, then we know that the allocation sequence is random and we can confidently answer yes. Okay. The guidance document states that if the only statement in the article states that randomization was done, then we can answer no information for this. Okay, because we don't know exactly what the randomization process was. And in case this hasn't been mentioned, then at all, then it goes to no. Okay. Question 1.2. Okay. Allocation sequence concealed. Is everyone clear with what is allocation sequence concealment? Can somebody explain? Can somebody please explain what is allocation sequence concealment? Is everybody familiar with the term allocation sequence concealment? Okay. So allocation sequence concealment is essentially that if I am the person allocating the participants recruited into the intervention group and the control group, then before the irreversible allocation, I am not aware that what is the allocation that will be given to the next participant. Is that clear? So, for instance, if I am the person to him I am the person who is recruiting the participants, I may be getting the like a team member of mine who is somewhere else is making the randomization sequence and is putting the random sequence numbers in sealed envelopes. It may be so that we have decided that if the participant gets an odd number, the participant will be in an intervention group, and if the participant is getting an even number, the participant will be in the control group. Okay. So my co-investigator who is at a different place may be generating the random number sequence and putting those numbers into the sealed envelopes, which they are then passing to me. So when the sealed envelope comes to me and I am recruiting the participant and I am passing the sealed envelope to them in an irreversible fashion. So I do not know that what is the allocation of the participant that I am just recruiting. Okay. So that is allocation sequence concealment. Okay. Is that clear?
Yes, ma'am.
So this is different from blinding in the sense that blinding is done after the allocation has been done. Okay. So allocation sequence concealment is before the allocation of the participant into the intervention or the control groups. Therefore, the sealed envelope process that I just mentioned is part of the allocation sequence concealment. However, if I'm giving the two participants, say the same colored tablet, okay, one is intervention and one is like the control, then that is patient level blinding. Okay. But we are talking here about allocation sequence concealment, which I just discussed through the sealed envelopes or other methods. Okay. So this was about the allocation sequence concealment. Now, 1.3 is, do baseline imbalances suggest a problem? So what does this mean? If baseline imbalances suggest a problem, means that we will see the characteristics of the intervention and the control group. So usually randomized trials often make this as the table 1 in their report. Okay. So what they will do is they will show the intervention and they will show the control group, and they will show that uh, the baseline characteristics such as age, sex, okay, and any other baseline characteristics that are relevant to the study, and they will show a p-value which should ideally not be significant. If it is significant, then it might suggest that the baseline imbalances are suggesting a problem. Okay. So now if we go for the entire algorithm, the first question turns out to be, is allocation sequence concealed? Okay. So if the answer is yes to this, if there has been allocation sequence concealment, we go on to the next question, where the next question is allocation sequence random? Okay. So this is about randomization. Again, if we are answering yes, then we go to the next question, which is, do baseline imbalances suggest a problem? If no, then this is a low risk trial, low risk of bias trial. If it is a yes or a probably yes, then this is some concerns. And if allocation sequence is random, it is coming as no, then it comes to some concerns. And baseline imbalances suggest a problem also no, after coming from here. If allocation sequence concealment there is no information and baseline imbalances are also not suggesting a problem, then we are coming to some concerns. But if baseline imbalances are suggesting a problem, or if it has been, if you can say for sure that allocation sequence has not been concealed, then this trial becomes at high risk of bias. Okay. Is that clear for domain 1? We will then move on to the next domain. Okay. So our next domain is bias due to deviations from the intended interventions. Okay. So bias due to deviations from the intended interventions. Okay. So now we all know about this kind of trials. Okay. What happens is that we are allocating participants into two groups. We may be allocating the participants into the intervention group and into the control group. But often it will happen that there will be deviations from the intended interventions. What this means is that some of the participants, though they were supposed to be taking the intervention drug or whatever interventional procedure, they are actually not following the intervention, and what they are doing is the control. Okay. And on the other hand, it may also happen that though some of the participants are supposed to be getting the control, but they are still going for the intervention. Okay. So these things do happen in trials. So there is so one of the types of bias that we do need to assess in our systematic review when we are doing for RCTs is to see the bias due to deviations from the intended interventions. Okay. So when we are looking at bias due to deviations from intended interventions, there are two ways in which we can see it. Two ways in which analysis is done, and there are two ways in which we can also be interested in understanding it. Okay. So the first one is the effect of assignment to intervention, and the second one is the effect of adhering to intervention. Okay. Can anybody explain what is the difference between these two? Effect of assignment to intervention and effect of adhering to intervention? So basically, effect of assignment to intervention is analyzing it as per whatever has been assigned, isn't it? So what has been assigned may be very different from what actually happened, isn't it? But when we are interested in effect of assignment to intervention, then we are going for one method of risk of bias assessment. And when we are more interested in the effect of adhering to intervention, effect of adhering to intervention means that how many people actually took the intervention, isn't it? Like who all actually followed the intervention as we had assigned. Okay. So these are the two methods in which the trials may be analyzed, or in which we may be interested in assessing the risk of bias assessment. Okay. So before even starting this domain 2 ka risk of bias assessment, we need to be clear what we are interested in. Okay. So when do you think it will be important to assess the effect of assignment to intervention? So it is more important to assess the effect of assignment to intervention when we are seeing something that will be implemented on a large scale, okay, like public health interventions. Okay. So for instance, if we are starting an exercise program for a large number of people, definitely not everyone is going to follow that intervention, isn't it? There are going to be a lot of dropouts, but that is what also reflects our real life scenario, isn't it? So that is why it is more important to assess the effect of assignment to intervention in such a case. Okay. And on the other hand, we will need to assess the effect of adhering to intervention in situations where clinical decisions are involved. So, for instance, if we want to see regarding the side effect of a certain drug that has been administered, okay, or regarding the uh, efficacy of a certain drug that is administered under supervision, okay, then it is more important to assess the effect of adhering to intervention. Okay, because this is something that is a clinical individualized decision that is being assessed. So first of all, we will go through the algorithm for the effect of assignment to intervention. Okay. So this is the algorithm for the effect of assignment to intervention. So what is this? First of all, 2.1 is that were the participants aware of the intervention? And 2.2 is that were the personnel aware of the intervention? So why is this important? Okay. So what is the concern when we are going through effect of assignment to intervention? So our main concern definitely is that we are assessing the effect of assignment to intervention, but if a large number of participants have changed from intervention to comparison and comparison to intervention, then the results that we find will not be, there will be a bias in that, isn't it? So that is why we need to find out, okay? And when will this problem be more? When participants are aware of the intervention, participants are more likely to not want the intervention or to not want the comparison and want to take the intervention, isn't it? So that increases the risk of bias. Okay. When personnel are aware of the intervention, that increases the risk of them either not administering the intervention properly to those who were supposed to be administered the intervention, or by administering interventional drugs to those who are not supposed to be administered the intervention. So if the answer to either of this is yes or probably yes or no information, then we get to 2.3. If the answer is no or probably no, it goes to low risk in this case. Okay. If the answer is yes, probably yes, or no information, then we come to the next question, which is like deviations that arose because of the trial context. So what this means is that were there deviations, which means people in intervention group not following the intervention or people in control group not following the control group, that arose because of the trial context, because of the way the trial was conducted. If the answer is no, then this becomes as low risk. If the answer is yes, then we move on to the next question. And if we have no information, then it becomes some concerns. Okay. The next question is, do the deviations affect the outcome? Okay. So it depends on the number of deviations. Okay. Usually, if there are any deviations, there is a chance that the outcome may be affected. Okay. We come to the next question. Were deviations balanced between the groups? Okay. So certain deviations may occur because participants are being lost to follow at a similar rate. Okay. Then this will become as deviations were balanced. Okay. But in case we see that the number of deviations are maybe not balanced, maybe they are more in the intervention group, then it becomes no and it goes to high risk. Okay. No or probably no. So this was part 1 of domain 2 for if we are analyzing according to the effect of assignment to intervention. Okay. So domain 2 is assessed in 2 parts if we were doing in for the effect of assignment to intervention. Now if we are doing part 2, then in part 2 we have 2.6 appropriate analysis to estimate the effect of assignment. So what are the appropriate analysis in randomized trials to estimate the effect of assignment? Can somebody answer? What are the methods of analysis that are done in the case of randomized trials? What are the methods of analysis that are done in the case of randomized trials? Anybody knows any methods of analysis that are done in the case of randomized trials? Yes. So intention to treat analysis is one of the methods. Exactly, Anjana. So intention to treat analysis, per protocol analysis are some of the methods that are done in the randomized trials. Okay. So in this case, What is the appropriate method? What is the appropriate method? Okay, so the common methods that are used for the analysis of randomized trials are the intention to treat analysis, and we also have the per protocol analysis or the as treated analysis. Okay, so what is the intention to treat analysis? Essentially, the intention to treat analysis means that participants are analyzed as per how they were assigned to the interventions. Okay, so whatever our intention was. So if like this a particular group has been assigned to intervention, we are analyzing them as if they were really in intervention. Okay, as with considering them as intervention only in the analysis. Okay, and the control group as control in the analysis. Okay, on the other hand, uh, if we go for the per protocol analysis, in per protocol analysis, what is done is that only those who have followed that, like in the intervention group, only those who have followed the intervention are included, and in the control group, only those who have followed the control treatment are included. Okay, so that is the per protocol analysis. And we also have the as treated analysis, where people are analyzed as per how exactly they have taken. Okay, so what is the problem with these types of analysis? So the problem with intention to treat analysis, the problem with intention to treat analysis is that the problem with intention to treat analysis is that whatever we may have assigned the groups as, the people may not have actually adhered to those interventions or the comparisons. Okay, if there are a large number of deviations, our results will be very biased. Okay, but on the other hand, if we are using the other methods, okay, such as per protocol or as treated, we are losing all the advantages of randomization, okay, that we have done. So that is why. Now, per protocol analysis and as treated analysis are considered inferior to intention to treat analysis, especially when we are seeing the effect of assignment to intervention. Okay. So, at least in this case, the appropriate analysis here, when we talk about 2.6, has appropriate analysis been done to estimate the effect of assignment? The appropriate analysis will be intention to treat analysis or modified intention to treat analysis. Only if the analysis has been done in ITT, that is intention to treat as analysis, or modified intention to treat analysis, will it be classified as low risk. Okay. If any other method of analysis has been used, such as per protocol analysis or as treated analysis, then we move on to the next question. Okay. So, has there been a substantial impact of the failure to analyze participants in the randomized group? Okay. If the answer is no, we go to some concerns. And if the answer is yes, we go to high risk. Okay. Now, again, the overall risk of bias for domain 2, how do we assess this? It's pretty much the same, the way we are assessing overall risk of bias. So, if both these are low, we go to low risk. If any of these is some concerns, it is some concerns. And if any of these is high risk, we will get high risk. Okay. This is domain 2 if we are assessing as per the effect of assignment to interventions. Okay. Now, how will we assess domain 2 if what we want to see is the effect of adhering to intervention? So, if we want to see the effect of adhering to intervention, this is the algorithm. Okay. So, our first question again is patients aware of the intervention, personnel aware of the intervention. Okay. So, the more this is yes, the more it means that it differs from what was the assignment to intervention. Okay. And the more there has been a problem with, if more people have deviated, that means the advantage of randomization has been lost. Okay. So if the answer is yes, then we have balanced non-protocol interventions. Okay. So what is balanced non-protocol interventions? It means that in both groups there is a disproportionate amount of uh, if there is a disproportionate amount of non-protocol interventions, okay, that means that it is not balanced, isn't it? So we go for no or probably no. Okay, we go to 2.6. In case it is balanced, then we go to the next questions, which are failure in implementation affecting outcome and non-adherence affecting outcome. Okay, so how much there have been the deviations. Okay, if it is no, it goes to low risk. If it is yes, we go to 2.6. Okay, appropriate analysis to estimate the effect of adhering. So what is the appropriate analysis here? Okay, so in what it turns out that even in the effect of adhering to interventions, per protocol analysis and as treated analysis are not considered acceptable. Okay, so in this case, like we need some very modified methods of analysis where they have done a staged analysis as per how many have dropped out, or if they have given the intervention as a one-time thing and there have been no changes. Okay, like there have been no deviations. Okay, so depending on that, we will either get yes or probably yes, which leads to some concerns, or we get no or probably no, which leads to high risk. Okay. Now we move on to domain 3. Okay. Domain 3 is about bias due to missing outcome data. Okay. Are things clear till now? Domain 1 and domain 2 is clear?
Yes, ma'am.
Yeah. Then we'll move on to domain 3. Okay. So domain 3 is the bias due to missing outcome data. Okay. So the first question, signaling question in domain 3 will be 3.1, which is the outcome data for all participants available. Okay. So we all know that in trials, as in prospective studies also, often it may be that all the participants may not come to us till the end for the outcome measurement. Okay, so this is pertaining to that. Okay, so 3.1 is outcome data available for all the participants. If it is yes, then automatically it goes to low risk in this domain. Okay, in case it is no, then our next question is evidence that the result is not biased. Okay. So what does this mean? Uh, so it means that we have some evidence that the missing data in the outcome is not biased. So there may be reasons for which the participants' outcome data is not available. Okay, legitimate reasons which have been mentioned earlier in the protocol, such as some participant has experienced some kind of an adverse event. Okay, for which they were not allowed to be administered the intervention. Okay, so if it is so, we again go to low risk. And if there is no evidence that the result is not biased, then we go to 3.3, where our question is missingness could depend on true value. So we know that there are certain characteristics of participants which might influence them to not come for follow-up for the outcome measurement. So for example, in the exercise program that we were talking about, suppose the participants who were not compliant did not turn up for outcome measurement. Okay, while participants who are more compliant did turn up for the outcome measurement. So in this case, missingness could depend on the true value, isn't it? So according to that, we go for low risk or we go to the next question. Okay. So the next question is that, is it likely that the missingness depended on the true value? Okay. This we will see after seeing the data that has been reported. Okay. if the data, by seeing the data, that shows some evidence that the missingness could have depended on the true value, then we go to high risk. And if there is no such evidence, then we go to no or probably no, which leads us to some concerns. Okay. So this was about domain 3. Okay. The next domain is domain 4, which is bias in the measurement of the outcome. Okay. So starting with bias in the measurement of the outcome, 4.1, our first signaling question is, was the method of measuring the outcome inappropriate? So we know that when outcomes are measured in trials, there can be so many methods of measuring the outcome. So for instance, if we are measuring the recovery from tuberculosis, then it could be measured by clinical resolution of the tuberculosis symptoms. It could be measured by microbiological confirmation. It could be measured by radiological confirmation, isn't it? Or if this was a trial that where the outcome was something such as depression, okay, then there are different scales that could have been used. Okay, so our first step is to understand, is to ask whether the method that had been used in this case for measuring the outcome, was it inappropriate? If it was inappropriate, then it automatically becomes as high risk. Okay. Our next question would be, measurement of ascertainment of outcome differ between the groups. Okay. So for instance, if the intervention group needs to come for follow-up more frequently than the control group and is having the outcome measurement done more frequently than the control group, then the answer to this question would be yes. On the other hand, if it is no, and that measurement was done equally in the different groups, then we go on to 4.3. Okay, so 4.3 is like, were the outcome assessors aware of the intervention received? Now you need to ask, who is the outcome assessor in this case? Okay, so for instance, if these are patient reported symptoms, then outcome is patient reported symptoms, then the outcome assessor is the patient. Okay, such as pain. Okay, if the outcome assessor is like, suppose the outcome is something like clinical resolution of the clinical resolution of, say, a lump. Okay, then the outcome assessor in this case is the clinician. Okay, or the outcome assessor assess outcome could be microbiological, such as sputum is negative for AFP. Okay, or that chest X-ray is clear. Okay, so if sputum is negative for AFP, that is the outcome. Then the outcome assessor becomes the microbiologist. Okay. So our question is, were the outcome assessors aware of the intervention received? If the answer is yes, okay, then this increases our risk of bias definitely. Okay, if the answer is no, then it goes to low risk. Okay, if the answer is yes, then would the assessment have been influenced by knowledge of the intervention? Okay, so what this means is like such, for example, in patient reported outcomes, if blinding has not been done and if the patient is aware whether they are having the intervention or the placebo or comparator, then they may, like, this would probably influence their assessment of the outcome, isn't it? So then that would become yes. Or if the clinician knew what is being given, okay, and the clinician is the outcome assessor, then again it is yes. If it is no, then it's low risk. If it is yes, we go on to the next one. Is it likely that the assessment was influenced by the knowledge of the intervention? Okay, here we usually see the data and then we take a decision. And then if we go to yes, it becomes high risk. If we go to no, it becomes some concerns. Okay. Similarly, from here, if we have no information for 4.2, these are the same questions. And similarly, as an algorithm, we will arrive to low risk, some concerns, or high risk. Okay. And now we come to the final domain in RoB2. Okay, so we have domain 5. Domain 5 is bias in the selection of the reported result. Okay, So I don't know if you remember the cartoon that we first saw in the first slide. So it was like the investigators were trying to only show the results that were favorable to them, isn't it? So this is related to that. Okay. So our first, so the 5.1 signaling question is, was the trial analyzed in accordance with a pre-specified plan? So for this, usually if possible, you should try to have access to the protocol. Okay. Was it analyzed as it had been mentioned in the protocol? And 5.2 is, was the result reported, that is selected from multiple outcome measurements. So for example, in the previous thing that we discussed, previous example, in the case of tuberculosis recovery, okay, suppose outcome has been measured clinically, it has been measured microbiologically, and it has been measured radiologically, but only one of these methods of outcome assessment is reported, then this does mean that result has been selected from multiple outcome measurements. Okay. Or the 5.3 is, has the result been selected from multiple analysis of the data? Okay, they have analyzed the data in different manners, and whatever was favorable to them, only that they have reported. Okay, so this is what it means. So coming to the algorithm, first of all, the question is, has the result been selected from multiple outcome measurements? Has the result been selected from multiple analysis of the data? If either of these questions is yes or probably yes, immediately it becomes high risk. If either of those questions is, if both of those questions are no, then we go to 5.1, which is, has it been analyzed as it had been mentioned in the protocol? If yes, it is low risk, sorry. And if it is no, or there is no information, it becomes some concerns. On the other hand, this one, if it was no information, at least one, but neither yes or probably yes, then we go to some concerns. Okay. So these are the 5 domains of risk of bias assessment in randomized trials. Okay. So in each of those 5 domains, as we have seen, as we complete the algorithm, we will get to the risk of bias assessment, okay, of each of these. Okay. And in each domain, we will get some answer, what it is. Okay. So this may be low risk, this may be some concerns, or this may be high risk. And the overall risk of bias assessment we will do by selecting the least favorable risk of bias assessment of all 5 domains. Okay. So this was about risk of bias assessment in randomized trials. Does anybody have any questions? Okay. If not, I think with ma'am's permission, we can move on to the next presentation by Aditi.
Yes, we can move ahead.
Thank you, ma'am.
Am I audible?
Yes, ma'am.
I will do now. I will just stop recording and start again. Huh?
Okay, ma'am.